Howdy, y'all. I'm Dr. Jeff Jarvis. Welcome to another webinar with NEMSQA and our partners at Prodigy. We want to take you through two of our measures, some of our most important measures, as a matter of fact, most important measures because they deal directly with our ability to safely do the job and get home to our families. We have an outstanding panel to speak with you today. The legendary Mike Taigman, Mr. Brian Maloney, and Alyssa Wim. We are going to talk you through these measures, not just what the measures are and how to use them, but we want to talk to you about some of the evidence behind the measures and give you some tips and tricks that we have learned as we have tried to work through a national quality improvement process about making our responses and our transports safer. So with that in mind, let's jump right into it, and let's start by taking a look at the measure. So Safety 01, the name gives this away. These are around safe responses to the scene and safe transports from the scene. So we'll start off. Safety 01 is the use of lights and sirens during response and transport. And the way this is set up, the way both of these are set up, is that a higher number means a safer response, a safer transport. And for some of the evidence, some of the reasons that we'll get into in a bit, responding without lights and sirens is actually safer than responding with. And again, we'll cover the whys of that. But that is the reason these are structured the way they are. So Safety 01 is the percentage of EMS responses to 911 calls in which lights and sirens were not used. And then Safety 02 is the identical measure, but for transport. So it's the number of transports without lights and sirens divided by the number of transports total. That's Safety 01 and 02. Now, I want to get into the evidence and the rationale behind this measure. So I'd like to do bluff. I like to get to the bottom line up front. So I'm going to give you my entire rationale for this in this slide, and then I'll give you some of the nerdy literature that says I didn't just make this up. So the first thing is lights and sirens are overused. Next up, using those lights and sirens is associated with an increase in collisions and fatalities and litigation. Those are three things we don't want to be associated with. We use lights and sirens because we think we need to get to the scene as soon as possible to do life-saving interventions. Well, it turns out that the use of lights and sirens doesn't save as much time as we assume that it does. And more importantly, the time that it does save almost never results in time-critical interventions that make a clinical difference to the patient. Next, I want to make the argument that the use of lights and sirens is a clinical intervention, and just like any clinical intervention, we should only use it when the potential benefits outweigh the potential harms. And then finally, because we may not necessarily subjectively know when those benefits outweigh the harms, I want to share with you a methodology that has been developed to help us identify how to objectively match our response mode to the things that are going to matter to patients, to the clinical differences. When we need to use lights and sirens, we want to give you a good methodology of determining how to use lights and sirens. So let's start off with where I get the notion that lights and sirens are overused. So if you have not been to the NEMSQA website, and I'm giving you the URL down below here, I would strongly urge you go to it. They have all of the NEMSQA measures, and you can go in just on this little pull down list and identify the NEMSQA measure that you want to see a benchmark on, and they will give you a benchmark based on NEMSQA data. And this particular one is on Safety 01. This is the proportion of calls without lights and sirens. And you will see that overall, 13% of 911 calls in the United States were run without lights and sirens. If you flip that over, that means my math is really bad, but 87% of calls used lights and sirens. That's an awful lot. And I think if you just on its face ask most of us with EMS experience, think back to the last time you used lights and sirens going to the scene of a 911 call. How often are you actually finding life-saving stuff that needs to be done? I think we all have the experience that that is probably not done 87% of the time. So you can see this number was calculated looking at 107 million 911 calls, over 14,000 agencies in 54 states and territories. This is a huge data set. So 13% of 911 calls did not have lights and sirens. If we look at the transports, thankfully, this number looks a lot better relative to responses, but still only 49% of transports to the emergency department did not use lights and sirens. Only 49% of the time were these the safest transport we could do. So I think they're overused. Next up, I made the argument that lights and sirens are associated with collisions, fatalities, and litigation. So let's take a look at some of the data. This was a paper published in the Annals of Emergency Medicine 2019, and what they did is looked at the NEMSQA data set, and they tried to figure out what the odds of being involved in a collision were using lights and sirens versus not using lights and sirens. So they calculated this for responses and for transports. If you're looking at responses using the NEMSQA data set, 19 million calls, and 74% of them used lights and sirens in that data set at that time. And then you can see transports, 13 million transports, and 22% of those used lights and sirens. If you look at the odds ratio is really simple. It's just the ratio of the odds. And what we see here is your odds of being in a collision when you're using lights and sirens compared to when you're not. That is 53% higher odds going to the scene and 184% higher odds of being in a collision using lights and sirens going to the hospital. Lights and sirens are associated with an increase in the risk of collision. It also turns out that most injuries and fatalities that are associated with collisions happen when we're using lights and sirens. This was a 10-year study of the FARS dataset, the Fatality Analysis Reporting System. What we see here is 60% of crashes occurred using lights and sirens, and 58% of fatalities were in those responses using lights and sirens. Lights and sirens associated with more collisions and more fatalities. So we said lights and sirens associated with more collisions, more fatalities. It's also associated with more litigation. And this is the interesting thing. The typical assumption is, well, I have to use lights and sirens because if I don't, I might get sued. And this study out of Denver that looked at all of their litigation, they broke it down into litigation associated with accidents. That's not what they found. They found that of these accident-related complaints, 59% of them used lights and sirens. I love the 31% where they got complaints and they weren't even moving. But I'm guessing somebody slammed into the back of an ambulance and blamed them for it. But 59% of these complaints involved the use of lights and sirens. Now, when you deal with litigation, 86% of those cases were around the use of lights and sirens. And most importantly, there were no cases in this data set that were for not using lights and sirens. And I've asked multiple EMS attorneys if they have ever heard of a case of being sued for going to a call without lights and sirens, and they were not aware of any. Next up, why are we using lights and sirens? Well, because it saves time. Turns out it might not save as much time as you think it does. Where do I get this data? Well, the best place for this is what is called a white paper. Dr. Doug Kupas wrote this white paper on a contract for NHTSA. The website is up there. Go download this PDF. It has a ton of really good information in it. Some of that information deals with how much time is saved. This was a literature survey of all of the papers that have been done on how much time was saved using lights and sirens. They broke it down into response time and transport time. And you can see here, dealing with responses going to the scene, these studies showed that using real world data, lights and sirens saved between 102 and 216 seconds. That comes out to a little somewhere between a minute and a half and 3.5 minutes. When I first drove lights and sirens as a, what in hindsight is probably a truly scary 18-year-old responding as a volunteer firefighter, I just assumed I was going to save 5 to 10 minutes every time I flipped those things on. Turns out much less time than at least I thought. Well, what about transports? These are the studies that looked at it, and we saved between 42 and 228 seconds. The average, again, is somewhere between 2.5 and 3.5 minutes. So why is it that using lights and sirens doesn't save us much time? Well, the only way it can save us time is as a communication strategy, kindly, ever so professionally, asking the drivers in front of us to please slowly and carefully move to the right, slow and stop, and allow us to pass. Most of us who have done this recognize that that isn't exactly what happened. This cartoon might make a little bit more sense to us about what it seems like people are actually doing, but you have to ask why. Why is it that they're doing it? Why do they seem like they're completely ignoring us? Well, there are two potential possibilities. One is that they're just a jerk, like this guy up in the right-hand corner. The other is that maybe they don't hear us, maybe they don't see us, and it turns out there is some evidence for this. And this is not exactly hot off the presses evidence. This is evidence that the DOT did back in 1977. And they set up some experiments to try to determine how far ahead of an emergency vehicle can other drivers hear our sirens. And what you'll see on the right is that bottom line turns out to be not very far. So when we are coming up on an intersection or another car, they're just not hearing us as far out as we think they are. And this was done in 1977 using state-of-the-art noise dampening solutions in 1977 vehicles. The vehicles we have now work a little bit better at that. I drive a new Tahoe, and you can set off a low yield tactical weapon right beside me, and I am probably not going to hear it. Our sirens are definitely not as effective as we think they are. Next up, we need to get there faster, so the theory goes, because we're going to save lives with the life-saving critical interventions that we do when we get there. Or the emergency department is going to do these time critical things as soon as we roll in. Well, it turns out, we got a couple papers to go over. It turns out that that doesn't actually happen. So if we are rushing to the emergency department, what is it we're actually rushing to? And if your system is anything like mine, this is what we're actually rushing to. We're rushing because apparently the walls of the hospital are about to cave in on themselves if we don't get there to hold those walls up. There are not a whole lot of time critical interventions being done in the ER. And if we actually think about it, think back to our last 1, 2, 300, 500 calls, and we'll realize that it's far more likely this is what we're rushing to. So let's get into the evidence. This was out of Colorado, looking at patients who were admitted for trauma, and they defined something called a time critical intervention, or a TCI. And that is life, limb, or eye saving procedures. And they said, well, let's just say these are rapid. We're going to just pick 15 minutes. And we want to find out how many of these patients who are, by definition, we're only getting into this bucket if they're already admitted for trauma. So these are the sickest of our sick patients. And what we found is that 23% of these patients had a time critical hospital intervention performed within 15 minutes. But the fascinating thing to me is you take a look at what those interventions were, and they were things like intubation, airway management, surgical airway, chest tubes. These are things to resolve conditions that we can do in the field. The whole reason we are there is to try to decrease the criticality of our patient. That's what we do. Let's take a look at essentially the same concept, but in New Jersey. And here, they actually tried to estimate how much time would be saved. And the way they did that was they got an EMS fellow, put them in a fly car, and they dispatched them to the scene of the collision, the scene of the emergency. And then the ambulance went lights and sirens to the hospital. The fellow in the fly car went via the same route, but without lights and sirens. And they just measured the time delta. And then they said, well, what is the rate of time critical interventions that were performed within that amount of time saved? Well, they found that they saved about 2.6 minutes, which is right in line with what Dr. Kupas found when he did the literature survey. The range, as you would expect, sometimes it's a lot of time saved. Sometimes it's actually takes more time going with lights and sirens. So 4.5% of these calls was there a time critical intervention at any time in the emergency department. None of those were within the amount of time that was saved. Louisville, doing the same thing, but this time using an off-duty paramedic as opposed to an EMS fellow. They looked at 17 of these calls. They saved 3.8 minutes, and they found that there were 14 or 19% of these had any hospital intervention at all, including starting a second life-saving IV. And then they said, well, how about the ones that were done within the amount of time saved? 4 of those, and that's 5%. And the interesting thing is, what were those 4%? Well, one was a re-intubation of an esophageally intubated patient. So EMS intubated the patient, and it turns out that it was in the esophagus upon EMS arrival. The other was an intubation of a patient that they could not get intubated in the field. One thing I have to say, being an airway nerd, is look at the date this was published. It was 1999. This was long before the standard availability of waveform capnography. I'd like to think this number would be much, much less. The other one was giving glucose to a hypoglycemic patient that we couldn't get an IV on. Again, take a look at the year. And then finally, giving Valium to a patient in status epilepticus. All of these things are things that we can and should treat in the field. So we're just not doing that much stuff. So the bottom line argument is, if not so much that we don't need to use lights and sirens, but that we need to use it intelligently. Lights and sirens are a clinical intervention, and we need to treat it like one. Just like we can intubate patients and defibrillate patients, but we're not going to intubate or defibrillate every patient just because we can. We shouldn't use lights and sirens just because we can. We should use it when it has the benefit of making a difference. Therefore, think about it like writing a prescription. We're going to use it as indicated and only as indicated. The key thing that I want to be very clear about is that's what we are saying. What are we not saying? Well, as a Texan, we have a saying you may have heard about cold, dead hands. Well, we are not saying that we're trying to take your lights and sirens and peel your cold, dead hands off of it. That's not what we're saying. Again, we're saying decrease the use to those times where it makes sense to use it. All right, now, well, how do we decide when to use it? Well, we can use our data to help us figure out how to use lights and sirens sparingly. Mike Taigman and 2 of our colleagues published this paper in PEC, and we took the ESO data set, 700 or 7.5 million 911 calls, and we said, here is a methodology that we think will work. Let's see what it looks like on this large data set. In this data set, we found 86% of 911 responses use lights and sirens, and we found that 13% use lights and sirens going to the hospital, about what we're seeing with the overall NEMSQA data set. And we looked at every intervention in the data set, and we had a consensus process where we each said, we think this is a potentially life-saving intervention, or PLSI, or we don't. We did a consensus process, came up with that final list, and then wrote code that said for each one of these 7.5 million calls, we're going to identify whether a potentially life-saving intervention was done on that call or not. And then for every EMD call determinant, we're going to group 911 calls together by determinant and calculate the percentage of life-saving interventions that were done for that call determinant. And what we found overall, was that 6.9% of all calls that we went lights and sirens to, did we do something clinically important, clinically life-saving. And with that, if we're going to the scene lights and sirens, and once we get there and assess the patient, we're only doing life-saving stuff 7% of the time. That means 93% of the time we're not. Maybe we can safely use this data to target our lights and sirens use. And what we estimated using this data set is overall, if we set a threshold to send a call lights and sirens based on the determinant and how often we do life-saving stuff for that determinant, we can, depending on the threshold, we can reduce our lights and sirens use. And as an example on that data set, if we set it at 5%, meaning we will use lights and sirens if we do something potentially life-saving more than 5% of the time, we can see a 47% reduction. If you set it at 10%, you'll see a 62% reduction. Now, we're not trying to suggest what you should set that threshold at. We're also not trying to suggest what are potentially life-saving interventions. As we mentioned in this paper, this is probably something that needs to be done at a local level. Well, that's what we looked at using retrospective national data. I wanted to take this methodology and implement it at my system and see what happened. So that's exactly what we did when I was at Williamson County. We implemented this exact same methodology. We got a group of people together to decide what the life-saving interventions were, and we got another group of people, including our elected officials, and we said, what threshold should we use? And we ended up with a threshold of 7.5%, meaning if there were 7.6% of calls within a given determinant that had a PLSI, we went lights and sirens. And what you see, this is preliminary data, we did a before and after response, and our no lights and sirens use went from 45% to 75%. So we were able to respond much more safely. A big question is, well, what does it do to your accuracy? Well, we defined accuracy as the number of hits divided by the total number of calls, where a hit is you go lights and sirens and do something life-saving, or you go without lights and sirens and don't do something life-saving. This is our balancing measure, and our accuracy went from 48% to 76%. It improved. Now, a lot of people want to know what it did to response times. Well, it increased them by about 20 seconds. So again, we were not saving as much time as we thought we were. So that's how we used that data to help us more safely respond. Now, the good news here is that if you decide to do this in your system, you're not acting on your own. There are a lot of people, a lot of organizations saying this is exactly what we should be doing. Specifically, these people, these organizations. There is a joint position statement that came out last year that said, hey guys, use lights and sirens as a clinical intervention only when indicated. Some of the specific things that it said in this position statement is that in some time-sensitive medical emergencies, lights and sirens may be worth it, may have an important impact on patient outcomes. But we should only use lights and sirens in those situations where we think the amount of time saved can be translated to a clinically important intervention. The position statement also says you should use EMD to identify which calls to use lights and sirens on. And most importantly to me, it said we recognize that there are agencies out there that use response time as the sole marker for clinical care and clinical quality, and you should use quality metrics rather than time metrics when you are building contractual obligations for EMS systems. So when you're defining the quality of the EMS system, base it on patient care, patient-oriented outcomes rather than time metrics. And just to be clear, when I say this, not speaking for the authors of the position statement, just for myself, I'm not saying response times never matter. There are some, which we've tried to identify with this methodology, where it's really important, and we do need to minimize those response times. But if you have gout, we probably don't need to get there as quickly as we might for, say, a cardiac arrest. That's what that says. Next up, we want to get to practical implementation strategies. So some tips. What can we actually do to move this measure? And for that, if we're talking about improvement, we should probably talk to the improvement guru himself, Mike Taigman. Mike, what you got for us?
Dr. Jarvis makes a really strong case for rethinking how we should use lights and siren in our own communities, and thinking about how to implement and improve safety in your own communities, safety for your patients, your providers, and for your community. It's a pretty vital thing. And as I know, this is a webinar that is focused on measurement, and I can't help but reflect on one of my favorite Palestinian proverbs that says, "You cannot fatten a cow by weighing it." Just measuring something doesn't actually change. So we need to take action to make meaningful and measurable improvement on the measures that we're tracking as part of NEMSQA here. One of the things we did is we chartered basically the first nationwide performance improvement project in the history of EMS focused on these two measures, Safety 01 and Safety 02. And we invited 50 EMS systems from across the country, all different sizes, shapes, and flavors, to participate in a project focused on collectively improving our performance around these two measures together. And to do this, we used the Institute for Healthcare Improvement's Breakthrough Series collaborative model for making improvement at scale and spreading it far and wide. So the way this model works is you basically identify something where there are places that have made meaningful, measurable improvements successfully using the model for improvement, which we'll get to here in a second. And you bring in other experts in the topic, and you basically work together to create a change package, and then have EMS systems tested all over the country, and basically share what they've learned as they've tried these things in their own systems in kind of an all teach and all learn perspective. So we recruited expert faculty from a number of EMS systems that have dramatically improved their performance in this area. We invited experts like Dr. Kupas, Dr. Jeff Clausen, Dr. Jeff Jarvis, research experts like Remley Crow and whatnot into this faculty to basically work together and develop what we call a change package, which is a list of actions to take in your own community. And then we brought people together and taught them the basics of improvement science. Fortunately, many of the participants already had some background in improvement science, and then set them to work making changes for 6 months in their organization before coming back together and sharing what we learned and kind of refining our change ideas and change package in the process. So the end of this process is the document that you've got from NEMSQA that describes exactly how to go through this work and make these improvements together. We used the Institute for Healthcare Improvement's model for improvement to guide our work around this as we work together in a collaborative. It starts with 3 questions. The first question is, what are we trying to accomplish? And what we're really trying to accomplish with this project is to reduce crashes, injuries, and death involving EMS vehicles. And the process measure for that is to reduce the use of lights and sirens for 911 calls in the response mode and the transport mode. Our goal was to have the responses without lights and sirens be greater than 70%, meaning 30% without the use of lights and sirens for response mode. And the transports without the use of lights and sirens, 95% or greater, meaning less than 5% of them are transported with the use of lights and sirens. Those are the measures that answer the question how we know that change is an improvement. And then what change can we make that will result in improvement is really the change package, and we'll walk you through some of those details here in a few minutes. And then the participating systems engaged in plan, do, study, act cycles, which is the learning engine that is used in improvement science, and shared everything they learned so that we could come together and refine our change ideas and practices. This online platform we used is called Simple QI. Really allowed all of the systems here, and here's a smattering of them, to be able to share their data, tracks it and run charts, shares all their PDSA cycles and all that together, and basically a refined package that says here's kind of the guidelines for what you can do in your own system to make these changes and make these improvements. So, start off any quality improvement project by gathering baseline data, and baseline data related to the two measures we're talking about here, and then several of the things that Dr. Jarvis foreshadowed for us, making the use of lights and siren a protocol within your clinical protocols, just like you would for droperidol or ketamine or the use of lidocaine, any of those kind of medications, thinking about lights and siren use in a similar vein so that it's actually written in to know what types of clinical cases would potentially benefit from that kind of 2 or 3 minute savings during transport, and it's actually very few. Eliminate the regulatory roadblocks. Many EMS systems have performance-based contracts for their providers that require response times within certain periods of time, and those kinds of things artificially incent the use of lights and sirens where maybe it's not clinically warranted or safe to do so. So examining those in your community and see what needs to be done to change those regulations. And you can change to more clinically relevant measures, not just response times. The response times measure was invented 35 some odd years ago, when that was really one of the only measures we had, and it was kind of a proxy for all the clinical care that we were doing back in the days when it was all paper medical records and those kinds of things. Our data systems and everything has evolved to the point where we can have clinical performance that we can hold our systems and providers accountable for, and not just response time performance. And then once you've got your data collected, analyze it and take a look through frameworks like Dr. Jarvis described, using your medical priority or other priority dispatch systems, so you can look at those determinants and see which ones actually resulted in potentially life-saving interventions. And for those that did get a potentially life-saving intervention within the first few minutes of arrival, you can certainly continue responding lights and sirens to those, but consider not responding lights and sirens to the ones where you've run hundreds of those calls and you provided no potentially life-saving interventions for those patients at all. That brings us to the end of this piece, and I want to transfer over to a leader in EMS who has become one of our role models in this project, who has made more dramatic improvement in a shorter period of time than almost any EMS system in America on this topic. So Brian, I'll let you take it away.
Mike, thank you very much for that introduction. I greatly appreciate it. And this is actually a great opportunity to work with this collaboration. Like Mike said, my name is Brian Maloney. I'm the Director of Operations for Plum Emergency Medical Services. We're actually located outside of the city of Pittsburgh in Allegheny County. And the area that we serve is about 30 square miles, has about a population of about 28,000 people. We are a 911 system only. We've been serving the area since 1991. We have a smaller organization with a total of about 26 employees. And when I even started back here in 2017, I was warned this was a tight-knit family. That was kind of an understatement. These people really work close together, take care of each other. And I tell you what, though, I landed an incredible location. The people are phenomenal. Probably the best thing about this organization, just like any other place else. So we have nice trucks, nice station, nice equipment, but the people is what truly makes a difference here. And so this actually started for us a little bit before this collaboration even started. So we kind of had somewhat of a jump start on it because one of the things that we do at Plum EMS, each week we typically review a protocol, policies, procedures, and typically like some type of training. It could be equipment, could be a case review. And so sometimes these protocols are chosen out of interesting cases we may have had. Sometimes it's just out of random. Now, in the state of Pennsylvania, we have statewide protocols, both ALS and BLS. And one of the times back, and I think it was at the end of 2017, maybe at the beginning of 2018, I saw that Pennsylvania actually has the statewide BLS protocol for the emergency vehicle operation safety. Now, this thing is like 3 or 4 pages, fine print. It's almost like an emergency vehicle operating course review. And so as I was going through all this, one of the things I actually found that was very interesting, we keep hearing this Dr. Kupis, and he was actually our state medical director that helped develop this protocol. Now, one of the benchmarks that I noticed as I was going through this is that there was a potential benchmark of less than 1% of the time of patients being transported to use lights and sirens. And I remember when I first looked at this, I thought maybe Dr. Kupis was sitting around a poker table one night with his friends thinking, how can I mess with EMS in the state of Pennsylvania? What can we do to really, mess with these people's heads? And I didn't truly appreciate it at the time. But then I'm always up for challenges and goals, as with the people that work at Plum EMS. And so I kind of did our research because you got to have that data, just like everything that's been talked about so far during this presentation. And I'll tell you what, we're at 26% of the time with the use of lights and sirens for transports back in 2017. So we kind of set on our goal for this. And so what we ended up doing, with just like any other approach that we have here, we kind of first focused on, okay, how often are we currently using lights and sirens? And we shared this data with folks, and we shared and reviewed this protocol. We talked about that 1%, performance or that parameter that we're shooting for. And we talked quite a bit, and there were conversations. There was never lectures. There was never, this is how it's going to be done. It was a dialogue. We heard people's concerns. We heard people's thoughts. And so that is pretty much how we started this. And so as this thing kind of evolved throughout the year, what we ended up doing is requiring a patient to complete basically a special report in our electronic patient care report anytime they use lights and sirens during transportation. And it was kind of, saying you need to justify the reasons why did you use lights and sirens. And, it was that kind of thing of it was a, fearful for their life or anything along those lines. But what that ended up doing is making people understand that they were accountable, that there was expectations and standards that we're now focusing on. And so that was a heck of an impact that we had when we first started this back in 2018. And what we also then started doing is, started providing feedback to crews. Now, I didn't have the capability of sending like a response vehicle to follow someone who used lights and we didn't, kind of thing. But what I did was I used Google Maps and I kind of took a look at, okay, how much time did they truly save? And I tried to do it about the same time. So I had an idea with traffic and everything. But I started providing these feedbacks of saying, first, of course, they had to do that special report, but then within 24 hours, they got an email from me. And that email was just, hey, I see that you had an interesting call, great documentation kind of thing. But then it was, listen, you saved, typically we never saved any more than 3 to 4 minutes whenever we use lights and sirens. And I always asked the question, did you think that truly made an impact on that patient's outcome? And that was one of the big things that we focused on. I never said anybody was wrong for using lights and sirens. I never, pretty much said, you can't do this. But it was that whole, I challenged them. I always challenged them to be the darn good EMS crew that they are. I challenged them to, go above and beyond and be aggressive with their treatments, and understanding that lights and sirens weren't always the answer. And so those discussions started. We were doing conversations and even case studies during our morning meetings. And a lot of times in these case studies, the moment we review it, a lot of times, majority, if not everybody, was like, lights and sirens weren't needed for this. And it wasn't to shame anybody, and because I never talked or brought up names when I did this, it was to talk about it and look at it from that 10,000-foot view and start looking at the details. Why did they choose that? STEMIs, strokes. Did it truly make a difference in that patient's outcome for that use of lights and sirens? Now, one of the other things that I started doing is that we actually have very close relationships with our local hospitals and receiving facilities. And anytime we use lights and sirens, I immediately sent an email to that hospital saying, hey, can I get a follow-up on that patient? So now in these emails that I started providing to the crew members, it was, of course, the time comparison, but it was also that, update on that patient. How did things go with that patient? What happened? And I'll tell you what, that made a heck of an impact when it came to it. But the other big thing, too, is when we started with this collaboration, it really had people stepping up. They loved being a part of it. They loved the challenge. They loved the idea of this. And we presented a lot of the data that was talked about throughout this presentation. And so the big question, is how did it go with the approach that we took? And remember, it was a very laid back, it was, dialogues, it was conversations. And I'll tell you what, in 2017, we were using lights and sirens during transport. I know this is kind of different than what everything we're talking about with the percentage wise, but the use of lights and sirens in 2017 was at 26.8%. Within that first year, we dropped it down to 12.2. Then it continued going down. And then in 2021, when we did this project, it even dropped down to 7%. So I'll tell you what, when we started that collaboration, I'm thinking we could hit that 5%, which that goal is. And I'll tell you what, in 2022, it dropped down to 4.24%, and we still monitor it today. In the second quarter of this year, they were down to use of lights and sirens during transport down to 3.5%. I keep weekly track of all this, and I post the results. And there are times, a couple times, where 0%, or that we didn't use lights or sirens. And so it's one of those things, that constant feedback. It's that constant, okay, this is now the culture. This is the atmosphere that we're doing with this. And so I was just completely dumbfounded and so impressed with how the team here at Plum EMS responded to this challenge. Now, I remember when, the goal for this collaboration for the use of lights and sirens for response, they were talking about less than 30% of the time. Now, in the Pennsylvania protocol, the potential benchmark for that identified by Dr. Kupis was less than 50% of the time. Now, in 2018, when we started looking at this, we were at like 46 or 48%. So I'm thinking, we got this. We're under that standard. We don't have to focus on that. It's not a big deal. But I remember with that collaboration when it came out and they said less than 30% of the time, I'm sitting there thinking, who do they think we are? We're EMS. Don't get me wrong. I got into EMS because I love helping people, but I'd be lying if I didn't say I enjoy going lights and sirens, that adrenaline, rush. And I love doing it. And so when this collaboration came out, and I'll tell you at less than 30% of the time, just blew my mind. I'm sitting there thinking, that's not who we are. But the other funny thing is I was sitting there thinking, and I even have in a lot of my other presentations about this, is that this is also when I kind of show a Top Gun, that, flying fast and all that, because that's who EMS is. But how often when those tones drop and we get that dispatch to a call, are we like a turtle? And it takes us 5-10 minutes to get out the door. But then when we hop in that truck, we're like, gung ho, we got to get there, got to go fast. Which that didn't seem to make much sense to me or even our organizations when we started talking about that. So this lights and sirens collaboration we already had that kind of thought process going because we've talked about this, with the safety of the crew, the patient, the community. And so this really helped us out. Now, with this second focus, we really started hard, big time on this in 2022. And just so you can kind of understand our system that we're currently in, we're in a county-based dispatch system. I love our TCOs. They are the best people I've ever met. It's just kind of our system definitely needs some improvement. But, with our system and the dispatches, we got an E0 to an E4, and it's probably similar to like most systems, with the E0 ALS unit, lights and sirens, they're recommending additional resources. E1 ALS unit, lights and sirens. E2 ALS unit, lights and sirens probably aren't needed, but it's kind of at the discretion of the crew. E3, E4, BLS, no lights, no sirens. Now, when we started this and kind of looked at this, January 1st to June 31st, when I looked at those numbers of 2022, we were using lights and sirens for E0, or we were dispatched just on about 50% of the time where it was recommending at least an ALS unit, lights and sirens. And so when I first looked, thought about that and did my research, we're at 48%. I think we're doing okay. E2s, 24% of the time, we're being dispatched like that. Now, one of the interesting things, especially when I was talking to neighboring agencies, they treated all E0s, E1s, E2s, lights and sirens. And so when you look at those numbers, that's like 75 or just under 75% of their responses, they used lights and sirens, which, is just absolutely crazy number. And even some of the numbers that we've heard previously. And so I realized we got a heck of a challenge, because if we're at 48%, how do we get it down below 30%? And so when we first started this, went back in even 2018, up until the collaboration, it wasn't a huge focus. It was a topic, because that topic was the safety of the crew, the safety of the patient, the safety of the community. We reviewed the protocol, but one of the big things that we focused on, because you think about those turtles, was getting out that door 60 seconds or less. From the time our tones drop to the time that truck is pulling out of the garage, 60 seconds or less. And some people are like, Brian, that's impossible, but it's not. It really isn't. I see my role here, as the management team does as well, that we are our biggest advocates for our people here. We are their biggest cheerleaders. We want to see them succeed, be safe, and come home. And when you look at all three of our garage door bays, every one of them has a huge sign on it that says "Come home safe," and we mean that. We're sincere about that. But we understand that the importance of getting that quick response time isn't going lights and sirens. It's getting out that door quicker. So that was a big push, especially when I started back in 2017, that we started focusing on. And so as this collaboration kind of started here, we focused on the protocol, we focused on shoot times, and that collaborative really had such a big impact on our organization. They liked the idea of a challenge. They liked the idea of being a part of something bigger than who we are. And so our weekly meetings, we talked about it. And we really encouraged the crews, don't just use that dispatch code. We are, privileged to have the information on our truck computers that we can go through the 911 notes or the TCO notes and look and see, are there any true, priority symptoms? Because unfortunately, we can get dispatched for abnormal blood work, and it's an E1 response, ALS crew lights and sirens. We can get dispatched for a new onset of AFib, E0 response. And you're thinking, what the heck does that have to, lights and sirens? That doesn't make sense. And so we sat up there and talked, and we're like, listen, what we want these crews to do is to sit back and take a look at the big picture, not just that dispatch code, but are there any priority symptoms? And then also, what is the day of the week, the time of the day, and the location of the call? And will lights and sirens truly make a difference as far as improving that? And so we've had a lot of talk during these meetings, and it was interesting. Once again, there were dialogues, there were conversations, but in these weekly meetings, people were concerned. They were concerned about, Brian, this is all that we've ever done. We don't use lights and sirens. We're going to get sued. We're going to be held liable if something bad happens. And when Dr. Jarvis was talking, he said there's no cases found or known of like an EMS agency being sued for not using lights and sirens, as long as they got out the door quickly. And so that was the big thing that we talked about. We talked about, and I really tried to hit home by saying, listen, if I got into a wreck on the way to a call or into the hospital and I hurt someone or worse, kill somebody, I don't know if I'd ever be able to step foot back in an emergency vehicle again. I just don't think I would be able to do it. And so what we really tried to do is take that approach of the impact that we could have if we got into a wreck. And the last thing that's even talked about here is that the management team here at Plum EMS also, we led by example. Let me tell you, after 25 years in EMS, going lights and sirens to a lot of my dispatches, it was so uncomfortable the first several times. It really was. I just I thought I was getting chest pain or something. But I remember one of the times we got called for a child seizing or having a seizure at a daycare. And I grabbed my stuff. I was going to back up the crew, hopped in my car, and I went. No lights, no sirens, stop signs, but I went. And I had a quick shoot time, meaning getting out that door. The crew, they didn't have that as a quick shoot time, and they decided to use lights and sirens. I still beat them on scene by 46 seconds. And that was the kind of thing that we talked about with these crew members. I never tell people that they're wrong what they do, but what I ask them to do is do the right thing and do the best thing for themselves, the patient, the community. That was what we really focused on. And with this collaboration and posting results and having conversations and helping people understand the impact, that they're having, it was amazing. Because back in 2021, we were up to 48% of the time with the use of lights and sirens responding to calls. Now, with this program, we dropped it down to 14.1%. And even in that first quarter, this calendar year, down to 10. In the second quarter, we were down to 5.5% of the time. And so the big question came down to, what about the differences in response times? When I took a look and did a comparison, we have a 37-second difference with our E0 responses and 66 seconds for E1s. And so we'll think about, once again, E1 for abnormal blood work, no priority symptoms, doesn't make any sense. And so these crew members and the team here has just gone above and beyond. I remember talking with one gentleman last week, and he even said, Brian, it's not even a challenge anymore. A lot of times we don't use them unless we come across a situation where traffic, construction, or something where we're like, okay, we got to get around this. And so they really did a phenomenal job of that. And I remember I had an opportunity to see a quote by Dr. Jeff Clausen, who's like the godfather of priority dispatch. And I remember this quote, and it really hit home because you can't prove based on public safety and medical literature that lights and sirens save more people than they kill. In fact, I can make the case that they kill more people than they save. And so one of the big things that we did with this program is we tried to be as transparent as possible. We ended up making sure we talked to our medical director because I didn't think anybody, I didn't want people to think that we were going rogue and going all crazy. And I remember our medical director, I was talking to her and I'm like, listen, I don't even have a policy on this. I don't have anything like that. I'm a little nervous about that. And I remember she was sitting there talking to me. She's like, Brian, these are people who have people's lives in their hands every day. I think they can make the right choice if they should use lights and sirens or not, both responding to calls or transporting to the hospital. And I'll tell you what, I love the way and what she said for that. One of my biggest challenges was our board of directors because they were so worried about that we could be jeopardizing care or our image within the community. But when we started this, I do monthly presentations for our local government council. I told them, this is what we're doing. And the reason why we're doing it is for the safety of our crews, the patient, and the community. And the fact that, by going lights and sirens while responding to a call, we increase our chances by 50% to get into a wreck. 50%. And then use of lights and sirens on the way to the hospital, we triple it. With that, just I'm not a gambling person, but those odds sound horrible. And why would I want to do that to myself, my colleagues, my patient, the community? And so, we talked with the police, and he made sure that police officers know who do respond to quite a bit of EMS calls that if it's a bad patient, just tell us, make sure you step it up. That's all we need to hear if we're not already using lights and sirens. Now, we're working with our public education as well, with the local media and a community magazine. But another big thing that we did, especially when we did this collaboration that I've learned from some of the colleagues that we worked with, is that we have a patient satisfaction survey that goes out to pretty much 100% of our patients. Any patient contact, they get it. And one of the questions asked on there was about our response times. We've never received anything lower than a 4 out of 5 for our response times. We've actually had a lot of people comment about how they appreciate us not coming through their neighborhood with lights and sirens. And if you think about it, a lot of times this is an embarrassing situation. There's a medical emergency and people need help, and they hate how all their neighbors come out to see what's going on. And so they really appreciated the fact that we got there quick, but didn't have to go through their neighborhoods with lights and sirens. Now, I remember having the conversations with crew members about lawsuits. They were so nervous about not using lights and sirens on the way to responding to a call because they thought they were going to get sued and there was going to be lawsuits against them. And once again, there's nothing found to have lawsuits against EMS not using lights and sirens, as long as there's that quick response or shoot time. But you sit there and go and take a look at all the lawsuits that are out there. A lot of the information that I even got when working on my presentation were from attorney websites. I mean, they have this stuff at the fingertips, and so if you look at all this, and I remember too, when I sat down and talked with the crew members, and the first couple of times I've done these presentations, I told people, listen, if I got into a wreck, I would never be able to step foot in the back in an emergency vehicle again. I just couldn't. And we had a very, very unfortunate incident with our neighboring agencies a couple months ago. In which an emergency vehicle got into a wreck on the way to a call they were responding to. And I never thought of it like this. Not only is there a chance that, we could hurt bystanders or community, but imagine sitting in that truck that you just got in a wreck in, and you had to watch your partner die right in front of you. And I mean, it's one of those things, every time I think about it, every time I say that out loud, I cry on the inside. It's that tough thing, but that's what can happen the moment we turn our lights on, whether it's responding to or transporting, we increase that likelihood. And so it's the kind of thing that, you got to ask yourself, is it truly worth it? Because it's one heck of a thing. Alyssa, why don't you go ahead and take it away?
All right, my name is Alyssa, and I am a project coordinator with NEMSQA. I've been a paramedic for 10 years, and I've got my master's in statistics and data science. I'm a big EMS research and data nerd, and I would like to go over the technical details on how to calculate these measures. So we're going to cover both Safety 01 and Safety 02. These measures look at the percent of EMS responses or transports without lights and sirens. Therefore, a higher score means decreased use of lights and sirens and better performance. So now let's go over how to calculate these measures. We're going to start with Safety 01, and then we'll go over the details for Safety 02. So Safety 01, the actual measure is the percentage of EMS responses originating from a 911 request during which lights and sirens were not used during response to the scene. So let's break down how we're going to calculate this percent score. Let's start with who's in, or the inclusion criteria. That's going to be all EMS responses originating from a 911 request. Well, how do we define that? We use the Data Bible or the NEMSQA Data Dictionary to find these definitions. So when we go back to these criteria, all EMS responses originating from a 911 request, we're going to use field E response 05, and this is what the pseudocode is to calculate that. We're not going to exclude anyone from our denominator for this particular measure. And for our numerator, or what counts, we're going to look at EMS responses during which lights and sirens were not used, using field E response 24. So this is what that pseudocode looks like. All right, for Safety 02, who's in? EMS transports originating from 911 request. So we're going to use E disposition 28 and 30 to identify transports, and then the same E response 05 to identify 911 request. And this is what that code looks like. And our measure, we're not excluding anyone from the denominator of this measure either. For Safety 02, the numerator, or what counts as the EMS transports during which lights and sirens were not used. And this is how we'll calculate that using field E disposition 18. So breaking it down, we're going to look at overall performance, but it's also great to take things one step further. So we're going to break these measures down into two groups. We're going to split them by the patients that are adults or greater than or equal to 18 years old and pediatrics, and see if our lights and sirens use is different based on the age of the patient. So this is how we would calculate that. I did have to simplify this pseudocode so it would fit on the slide. However, you are able to access the full pseudocode for all of these measures on the NEMSQA.org website. You must create a free account to access the pseudocode, but this is so we can communicate with you when there are changes made to these measures. You can also, on this website, run a benchmark performance on the NEMSIS public dashboard, which Jeff Jarvis referred to during his part. That's here on the resources tab. And also on our website, we're going to have vendor software demos. So it'll be under the same resources tab. We'll have the EPCR vendors showing a demonstration on how to calculate each of these measures on their specific data analytics platform.